Hello, my name is Barbee Cunningham. I'm a graduate student with the nursing school at West Texas A&M University. I'm going to do a head-to-toe assessment on my patient, Luke. He is a 36-year-old male. We have completed the general survey, including the past medical history, past surgical history, and allergy. He's allergic to aspirin. I have obtained a complete set of vital signs, and they were all within normal limits, and his height and weight. I have washed my hands, and we're going to start our assessment. I have completed a visual exam on the cranial nerve 2, the optic nerve, with the Snellen E chart prior to us starting. I'm going to visually inspect the head to start out with, making sure that the ears are symmetrical, the eyes are symmetrical, nose is midline, mouth is midline. There's no abnormal swelling, bruising, or deformities that I can see. I'm going to test cranial nerve number 2, the trigeminal, by having the patient close his eyes and tell me if he feels something sharp or dull.
Dull. Sharp. 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 Dull. Dull.
And the cranial nerve, the trigeminal nerve is intact. I'm going to palpate his scalp, looking at his hair distribution, making sure there's no lesions, bony prominences, or nodules or abnormal swelling, showing any scalp deformities. And I don't feel it. Everything feels normal. I'm going to look at the eyes. I'm going to check the eyelids, upper and lower, on both eyes, making sure there's no swelling or irritation. There's no abnormal tearing or discharge. That the sclera is nice and white as opposed to red, which is a sign of irritation or infection, or yellow, which is a sign of jaundice. And the sclera is nice and white. I'm going to check the conjunctiva to make sure it's nice and pink and moist. And it's nice and pink. And then raise the eyebrows. Yep. Everything looks good. I'm going to check pupillary response for direct and consensual on both eyes. So if you'll just look at me, direct and consensual, direct and consensual. While I'm here, I'm going to be looking at the lens, making sure it's nice and clear, and then looking at the retina to make sure I can see the red reflex and the vessels in the back, in the posterior eye. I'm going to anchor my hand on his forehead and look in the eye. Nice red reflex. The eye vessels look good. And there's a red reflex. And the lens is clear in both eyes. I'm going to test a combination by having optic nerves by having him focus on my finger, and then focus on the wall, focus on my finger, and focus on the wall. I'm going to test cranial nerves 3, 4, and 6, the ocular motor, the trochlear, and the abducens, by checking his fields of vision, making sure there's no nystagmus as we're moving around. If you could leave your head still, and then follow my finger as I move it. And there's no nystagmus noted. I'm going to go ahead and move on to inspection of the ears. Visually inspect, making sure they're symmetrical, that I do not have any abnormal swelling or nodules. And I'm going to palpate for swelling, nodules, or tenderness. I don't feel any. I'm going to go ahead and check the tympanic membrane. For an adult, I'm going to pull it up and back, and making sure the tympanic membrane is intact, light gray, there's no irritation or discharge, and this tympanic membrane looks good. Do the left ear. The tympanic membrane is intact, no bulging or redness. I'm going to go ahead and do the whisper test. If you'll repeat after me.
44.
And on this side.
This side.
To finish checking his hearing, I'm going to check the cranial nerve number 8, the auditory nerve, by doing the Weber and the Rhine test with a tuning fork. So I'm going to hit the tuning fork and place it on the top of your head. I want you to tell me if you hear equally in both ears.
Yes.
Okay, and now we're going to do that was a Weber test. Now we're going to do the Rhine test. To test bone to air conduction, it should be a 2-to-1 ratio. So I'm going to place the tuning fork on the back of your ear, tell me when you can no longer hear it, and then place it in front of your ear and tell me when you can no longer hear it. And on the left ear. Thank you. As part of the nose assessment, I forgot to test the cranial nerve number 1, the olfactory nerve. So I'm going to have the patient close his eyes and tell me what he can smell.
Alcohol.
And on the other side.
Alcohol.
Thank you. We've tested the hearing. We're going to go ahead and look at the mouth, making sure the lips are nice and moist, nice and pink. There's no cracking or ulcerations on the outside. Then I'm going to have the patient open his mouth. I'm going to check ulcerations on the cheeks, the hard and soft palate, any swelling in the gums, any missing or cracked or potential cavities on the teeth. Checking to make sure he has good oral hygiene. If you will open your mouth and stick your tongue through the roof of your mouth. I'm checking for the vasculature under the tongue. I'm going to check cranial nerve number 9, the glossopharyngeal, by checking the gag reflex. So open, and he gags perfectly. I'm going to check cranial nerve number 10, the vagus nerve, by having the patient stick out his tongue and say ah. And the uvula raises nice and midline. I also checked the back of the throat to see if there was any redness or cobblestoning. If the tonsils, one of the tonsils was enlarged, his tonsils are small and present. And the back of the throat is nice and pink, not red at all. There is no postnasal drip. I'm going to check the cranial nerve number 12, the hypoglossal nerve, by having the patient stick out his tongue and then wiggle it side to side. Also checking the sides of the tongue to make sure there's no ulcerations and there's nothing abnormal in the oral cavity. I'm going to go ahead and check cranial nerve 12. No, that was cranial nerve 12. Cranial nerve 7, the facial nerve, by having him smile really big and then close your mouth and puff out your cheeks. And that nerve is intact. Last cranial nerve is the accessory muscle or accessory nerve, by having him shrug his shoulders against his face. And that completes the head assessment. No, it doesn't. I'm going to palpate his temporal arteries, making sure they're nice and strong. And then I'm going to palpate his lymph nodes. So the pre-auricle, post-auricle, I'm checking for any swelling or any palpable lymph nodes. The submandibular, the submantle, the cervical, the post-cervical, and the supraclavicular. And if you'll raise your arms a little bit, I'm going to check the axillary, and I don't have any, I'm unable to palpate any of the lymph nodes abnormal size, or is there any tenderness? And no tenderness reported. I'm going to have the patient check range of motion of the neck. I'm going to have him put his left ear to his left shoulder, right ear to right shoulder. Look up and look down. So he has full range of motion. Do you have any tenderness while you're moving your neck? No? I'm going to palpate the thyroid, see if I feel any nodules, and then have the patient swallow. Do you have any pain when you swallow?
No.
So the thyroid appears to be normal. I'm going to palpate the carotid pulses one at a time because we don't want the patient to get dizzy by occluding blood flow to the brain. Making sure it's nice and strong. And then I'm going to grab my stethoscope and I'm going to listen to the carotid pulses one at a time, making sure that there's no brewing. And I don't hear any brewing. I'm going to have the patient turn away from the camera, just swing this way, and just sit on the side of the bed so I can assess the posterior chest. First, I'm going to inspect, making sure there's no signs of labored breathing, like accessory muscle use. There's equal rise and fall of the chest. I'm going to test for expansion and then test for tactile expansion. So I'm going to put my hands here and have it take a deep breath in and watching my hands, how far they expand, and that's a good expansion. I'm going to assess tactile parameters by having the patient say 99.
99.
One more time. That feels good. I'm going to percuss the lung field. Checking for any sound, resonant sounds. Hyperresonance means COPD or asthma or dullness for fluid buildup like in pneumonia. And everything sounds normal when I percuss. I'm going to percuss for diaphragmatic excursion. So if you'll take a deep breath and hold it. Find the line of dullness and then exhale. And then take a deep breath, exhale, and hold it. And then I'm going to measure between those two markers that I made. I'm going to auscultate breath sounds using a ladder pattern in all lung fields. Just breathe. I'm also going to check lateral lung sounds. And all lung sounds are clear. Now I'm going to check bronchoscopy, cacophony, and whispered pictorial slowly by having the patient say 99 and E while I auscultate. Say 99.
99.
Okay.
99.
Okay.
99. 99.
And say E. Okay. 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 And all those sounds are normal. Now I'm going to have the patient turn back towards the camera. And now we're going to inspect the anterior chest. I'm going to move your counters. Making sure there's no signs of labored breathing, there's equal chest rise and fall, and there's no abnormal swelling or bruising on it. I'm going to go ahead and palpate the lung fields again from the anterior. That sounds good. And then, oh no, I'm sorry. I was percussing the lung fields. Now I'm going to palpate the chest using the ball of my hand and my fingers. See if I feel anything abnormal. And then I already percussed, and now I'm going to auscultate all the lung fields. Using a ladder pattern. Including the lateral lungs. And the lung sounds clear from the anterior chest also. I'm going to palpate or auscultate the heart. I'm going to start with the second intercostal space on the right sternal border for the aortic, the second intercostal space on the left sternal border for the pulmonic, the third intercostal space on the left sternal border, the fourth intercostal space on the left sternal border for the tricuspid, and the fifth intercostal space on the midclavicular line for the apex of the heart or the mitral area. Listening for S1, S2, no abnormal pulse sounds, no friction rubs, gallops. Now I'm going to flip over to the bell of my stethoscope and listen for any murmurs from the base to the apex of the heart. Only S1 and S2 are heard. There are no murmurs present. I'm going to palpate the apex of the heart, making sure I can feel it. I would need to go more laterally if I suspected that he had cardiomegaly, enlarged heart. So everything on the chest looks good. I'm going to have you scoot back in the bed. Put you down. I'm going to lower the head of the bed to 30 degrees so we can check for JVD. I'm going to stick a centimeter ruler on the sternal margin. If you'll turn your head just slightly away from me, not that far, right there. Stick that up and then put a note card or something flat at the meningus to check for JVD. Normal in an adult is 3 to 4 centimeters, and his is just under 4. So while he's laying down, I'm going to lay the head of the bed flat. I'm going to raise the gown, making sure he's still covered to inspect his abdomen. I'm looking for any paresthesia, any masses, any bruising around the umbilicus that I can see, and his abdomen appears to be normal. I'm going to auscultate for breath sound or vowel sounds in all 4 quadrants. Making sure that they're normal and not hypo or hypoactive. And vowel sounds are normal. I'm going to go ahead and while I've got my stethoscope, listen to the aorta. And the femoral artery. I'm going to percuss in all 4 quadrants of the abdomen. Listening for tympany or dullness. I'm going to percuss the lower border of the liver at the midclavicular line. There's that. And then I'm going to go from try to find the upper border of the liver for dullness. And roughly how big the liver is, making sure it's not enlarged. I'm going to percuss the spleen. Checking for a normal size. Now I'm going to lightly palpate all 4 quadrants of the abdomen. Making sure I don't feel any masses in his abdomen. Now I'm going to deeply palpate the liver by putting my left hand underneath his back and try to push hard with my right hand, trying to figure out if it's nice and smooth. The liver feels good, feels like normal size. Now I'm going to try to palpate the spleen. In a normal adult, it's very difficult to palpate the spleen. And I can't palpate the spleen. I'm going to try to palpate the kidneys, checking for any tenderness. No tenderness on that side. He appears to be not grimacing, so no tenderness on that side. I'm going to, while he's laying on his back, I'm going to raise his leg and have him dorsiflex his foot to see if there's any sign of herniated disc in his lower back. So flex your foot. Any pain in your back? No pain reported. And this side. And flex your foot. No pain reported. So that's abdomen. I will ask him about questions about his, if he's having any dysuria or bladder distension or frequent voiding at night. If he's noticed any lesions or swelling on his scrotum or penis. If he's having any dysuria or discharge. And ask him about his bowel patterns. If he's having frequent bouts of constipation or diarrhea, or if he has regular bowel movements as part of the abdominal and pelvic extent. I'm going to check range of motion of his lower extremities, starting with the hip. So I'm going to have you with right leg flex. So flexion of the hip and extension of the hip, adduction of the hip, abduction of the hip, adduction of the hip, and then external rotation, internal rotation. That hip appears to be intact. Making sure that he doesn't have any pain while we're performing any of these movements. So now we're going to do the left hip. Okay. Flexion. Flexion of the hip, extension of the hip, abduction of the hip, abduction of the hip, external rotation, and internal rotation. So that hip appears to be having full range of motion. Now we're going to do the left knee. So flex your knee, extend your knee, externally rotate, internally rotate. That knee is intact. Now we're going to go back to the right side. Check range of motion of the right knee. Flex your knee, extend your knee, external rotation, internal rotation, intact. Now we're going to check muscle strength and ankle range of motion by having the patient plantar flex his feet and dorsal flex his feet. So if you'll push on my hands, thank you, pull, very good. Legs appear to be even, no atrophy of muscles, range of motion of the ankles is intact. So we checked range of motion of the legs. Now I'm going to have him sit up and scoot to the end of the bed. While I'm at the back, I forgot to check costovertebral tenderness, CVA tenderness. So I'm going to palpate his back, and he's going to let me know if he has any pain. Is it?
No.
This one?
No.
Okay. So now we're going to do range of motion of the arms. So I'm going to have you raise your arms straight out, abduction of the arms, and then cross them. Adduction of the arms, that's good. And then put your hands behind your head for external rotation, and then hands behind your ribs for internal rotation. So the shoulders, do you have any pain while you're rotating? So shoulder has full range of motion. Now we're going to do range of motion of the elbows. And test muscle strength in the arms. I'm going to have him pull and push me away while he's flexing and extending. So if you'll push me away to extend, thank you, and then pull towards, flex, thank you. And now I'm going to test his range of motion of his wrists by having him supinate and pronate his hands. So if you'll hold out your hands, flip them over, and flip them back, over, and back. And now I'm going to test cerebral function by having him do it quickly. Pronate and supinate quickly. That's very good. You'll relax your hands a little bit. I'm going to test the neurosensory by having him hold out one palm. And I'm going to draw a number on his palm. If you'll close your eyes, tell me if you can identify the number.
3.
Thank you. And I'm going to place an object in your hand. I want you to identify what the object is. Close and identify.
Key.
Very good. And one more time.
Ball.
Thank you. I'm going to test the neurosensory by doing the I'm going to have him hold out his hands, and I'm going to touch a finger, have him close his eyes, touch a finger, and have whichever finger I touch point to his nose, go to his nose. And one more time. Very good. If you'll scoot back on the bed just a little bit, have your feet dangle. I'm going to check the neurosensory in your toes. I'm going to lift or lower one of your toes, and you'll tell me if I'm lifting or lowering.
Lower. Lift. Lower. Up.
Lift. Thank you. His neurosensory is intact in his extremities. I'm going to go ahead and finish checking his pulses. I've already checked the temporal pulse and the carotid pulse. Now I'm going to check the brachial pulse. Making sure they're strong and regular, but not bounding. And the radial pulse. and that's good. I'm going to check the pulses in the legs. I've already checked the femoral, so I'm going to check the popliteal pulse using both hands. That one's strong and regular without bounding. Strong and regular without bounding. I'm going to go ahead and check the posterior tibial pulse. Making sure they're strong and equal. And the dorsalis pedis on the top of the foot. They are strong and equal. While I'm looking at the legs, just making sure there's no swelling, lesions, abnormal discoloration, hair distribution, or clubbing of his toenails, showing impaired circulation. And capillary refill. Or abnormal muscles in one leg or the other, bigger or littler. But the legs appear to be symmetric, capillary refills intact, circulation looks good. I'm going to test the reflexes. Do the right arm first. Hold your arm out, kind of just let it relax. Thank you. And good. And then the brachial radial. Very good. And the knee. And the Achilles. Reflexes appear to be intact. Now I'm going to check ataxia to make sure his balance is intact. He'll stand up. Step forward just a little bit. And close your eyes. I'm just going to hold my hands up to just make sure he's not going to fall. Also, while I'm lateral, I'm going to make sure he's not having a barrel chest. But his anterior lateral chest is fine. I'm going to go ahead and open your eyes. I'm going to check his spine. If you'll bend down and touch your toes. I'm going to check the SI joints. Those are good. Making sure the spine is midline. There's no abnormal curvatures like in scoliosis. If you'll raise up a little bit right there. Making sure, once again, spine is midline and there's no abnormal curvatures. You can stand all the way up. I'm going to check his gait. You'll stand over here. And I want you to walk heel-toe forward and then turn around. And walk on your toes and then on your heels. And his gait appears to be intact. You'll have some. That concludes our physical exam. With a female, I would talk about, when I was inspecting the chest, talk about doing a breast exam, starting in the axillary and working in a snake pattern, up and down until we reach the medial line, feeling for any abnormalities, tenderness, or nodules. You can teach a man to do a breast exam, but men don't typically have breast cancer like women do. We've already talked about if he has any dysuria with his genitalia. I would inspect his glands and the shaft and the scrotal sac and the testicles, make sure there's no swelling, tenderness, or abnormal lesions. Making sure there's no redness. I would do a rectal exam, which checking externally, making sure there's no hemorrhoids, checking to make sure the sphincter tone is intact or not too hypersensitive. If his sphincter tone is not hypersensitive, then I could palpate the sphincter and then do a digital rectal exam by check the prostate, make sure it's nice and smooth and not boggy. Making sure there's no polyps in the rectal canal or any abnormal masses or stool in the rectal vault or blood in the rectal vault. This concludes my complete head to toe assessment. Thank you.